Good afternoon. Now that we have a quorum, the Senate Finance Committee is in session. Colleagues, please take your seats. The first bill that we're going to hear this afternoon is Senate Bill 859, Senator Watson. Senator, you may either stand at the podium or sit at the table. The mics in both locations. And let's see, you have a couple of people that we're going to call up, Tanika Hoffman and Derek Robertson. Yeah. If they would take a seat at the table. The mics at the table are movable. All right.
Thank you, Madam Chair and committee members. You said we're starting with 859?
Yes.
All right. For the record, I'm Senator Ron Watson, representing the 23rd Legislative District. Good afternoon, everybody. Public Health Sickle Cell Disease Registry establishment. This bill requires the Maryland Department of Health to establish and maintain a registry of individuals diagnosed with sickle cell disease. The purpose of the registry is to serve as a single repository of accurate, complete records to aid in promoting the sitting of hematologists' offices and healthcare facilities that provide infusion therapies in areas of the state with high populations of individuals with sickle cell. The registry must include any other information regarding individuals diagnosed with sickle cell that the Department of Health considers necessary and appropriate. A healthcare provider who serves individuals with sickle cell must provide specified information to the Department of Health in the form and the manner required. I'm here with some very good experts, and I would ask a favorable report, and I look forward to them answering some questions.
Okay, well, let me just ask you, what is the problem right now that you really are trying to solve?
I really would like my expert to handle that, Madam Chair, if you don't mind.
Okay, all right.
Madam Chair, the fundamental issue is that we don't know how many people in the state of Maryland have sickle cell disease, and that makes it very challenging to develop public health policies and strategies. And that's really the purpose of the registry.
All right. Well, let me ask this. What are you going to do? Have a public interest campaign that will be advertised broadly in order to even find them?
Thank you, Madam Chair. No, generally it goes through the treaters, so that the registry is going to come out of the major institutions that treat sickle cell, both in Baltimore and Washington, D.C. That's like the low-hanging fruit, so to speak. And then after that, yes, there will be outreach and awareness campaigns. So generally, we have a sense of where folks are, but what happens is that when they seek care, there's no way to collect that information. So if, for example, Johns Hopkins has the major facility in Maryland, if somebody is seen at Chesapeake Regional in Harford County, that information doesn't necessarily translate back so that we have a collective information to know where all the patients are.
Okay.
It's just,
but let me say this. We are more ignorant than you might think. We don't know who the we is. Who is it that needs the information and needs to know the size of the pool of people in Maryland and where they're located? And what are you going to do with the information?
so ultimately, it's a benefit to the people who have sickle cell disease, because when the public health officials and the hematologists know where they are, as the bill says, it allows you to target resources that can help these patients. I think the analogy that you look at nationally is the National Cancer Registry, for example, where with that registry, you're able to determine outcomes, you're able to determine treatments, you're able to determine a lot of information about comorbidities. So, for example, you'll hear from Tanika, who has sickle cell disease and also kidney disease. We know that information is out there. When you have a population look at, then you can develop more strategies and outcomes
Sure.
and how exactly that can be done.
That certainly makes a lot of sense. Let me ask one last thing. When you do your outreach, how do you expect to do it? What modalities will you use? You want to use newspaper announcements, or are you just going to contact doctors' offices not knowing? I mean, you got a lot of physicians in Maryland.
So, yeah, so we will be utilizing CRISP, and forgive me, I don't know what it stands for, but they're the Health Information Exchange from Maryland. Mm-hmm. So a lot of this data is already being collected. However, it's not being put in a very concise way and a collective way. So it's not so much that we'll be doing public outreach, but it's collecting the data that's there. And then also we can have patients who can voluntarily sign up to be on that registry. So it's using the technology that already exists to bring this data together.
Thank you. All right, then we're going to Ms. Tanika Hoffman.
Thank you, Madam Chair. My name is Tanika Hoffman, and I've lived in Maryland with sickle cell disease for the majority of my life. The lack of resources available to me since childhood has always placed me at a disadvantage compared to other peers who have other chronic illnesses. From having to travel to Children's National in Washington, D.C. for care as a child, to being a part of schools in Prince George's County who don't have nurses who are qualified to treat me, and having to go to school outside of my district to be safe. Once I became a young adult, several years back, at the most critical time for a sickle cell disease warrior as far as life, from pediatrics to transitioning into adulthood, I had no hematologist available to me in the state of Maryland that was close to me. So that meant that I would have to travel to Alexandria for care to seek a hematologist. As a Mailander with SCD, the approval of the bill would mean that protocols could be put in place for providers in my particular county, Prince George's County, to adequately train physicians in the care of sickle cell disease, but also to create protocol to help strengthen the knowledge that it's already out there. The approval of Bill 859 would also give the state a holistic picture of the sickle cell disease population. This would mean that we would get a better understanding, for example, how many sickle cell warriors have gone blind because of crisis in their eyes, or understanding how many individuals might suffer from kidney disease, because as we know, sickle cell disease affects the entire body as blood flows through the entire body. So it can be very destructive to our organs because our blood cells cannot carry oxygen appropriately. It would also help us to be able to create budgets and understand the finance that it would need to be able to serve the broader sickle cell population. And so I hope that it would be a favorable approval for this bill, and thank you so much for your time and for listening. Thank you.
You educated us very well. Are there any questions? All right, then I guess that ends the testimony on this bill, and thank you very much. Okay, now, Ms. Senator, you got a second bill, 883, Public Health Sickle Cell Disease Testing at a Community-Based Health Fair. And so we have the same persons testifying as witnesses, and you may go in whatever order you decide. You have 2 minutes each.
Thank you, Madam Chair. Just briefly, this is the other piece which provides for testing at community-based fairs and answers some of your other questions, where these testing facilities will be done by a qualified person as determined by the Department of Health to offer the testing, but also to distribute information in areas underserved by service providers that are trained in the diagnosis and treatment of the chronic conditions suffered as a result of this disease. Testing and subsequent counseling will aid those in the future to make decisions about family planning. Test and health fairs could be conducted to offset those areas that have a high concentration of sickle cell.
Thank you.
Thank you.
All right.
Thank you, Senator, and thank you, Madam Chair. Yes, this bill is very important. We had mentioned, your first question was about outreach and awareness, and this bill will certainly help in that regard. One of the things that we do know is that 1 in 12 people of African descent carry the sickle cell trait. And we know that that's really, people don't know you get that result at newborn, but by the time you grow up, most people don't remember their newborn screening results. Having this ability to test at community health fairs will certainly reach that, and there are 2 primary reasons for doing that. The first is that there are rare complications of sickle cell trait, where people can have a rare form of kidney disease. They usually have blood in their urine, and it can be symptomatic. So you want to be able to discuss that with your healthcare provider. And then, as the Senator mentioned, we want individuals to be able to make informed reproductive decisions. It's a very sensitive area. I have 2 children with sickle cell disease, and I have gotten looks like, how could you have a second? We regard children as a blessing, but what we want folks to be able to do is to make that informed decision so that they're not surprised if they get if they have a baby with sickle cell disease, they're prepared for it. And so those are the two major reasons for having this. Currently, there's an inability for mobile testing facilities to test at community health fairs because current regulations restrict that to non-diagnostic testing. And so this is potentially diagnostic in that you could find out that you have sickle cell disease. It would be rare, but you can. And so that's why we need this bill to help with the awareness, and it would go very well paired with 859, which would be the registry. So
Okay.
thank you so much. I'll turn it over to Ms. Hoffman.
Thank you. All right, and now, Ms. Hoffman?
Thank you, Madam Chair. I was tested for sickle cell disease at Children's National at the age of 2 years old when I was in the process of a workup for a surgery. My family had no idea that I had sickle cell disease until this testing for surgery, and my surgery was canceled. I am one of thousands of individuals with sickle cell disease who sometimes don't find out that they have sickle cell disease until they're born and they get the latter 2 to 3 weeks from birth. But in my particular case, I was missed. The story continues to happen again and again, especially for those who have sickle cell trait. A lot of patients do not know their status, and unfortunately, when a child is born, they are devastated and they find out my baby has sickle cell disease, and they had no idea they had sickle cell trait or any other hemoglobinopathies when paired with sickle cell trait that creates different forms of sickle cell disease. And so the approval of this bill would mean that we can begin to empower and inform our community on their genetic history through community health fairs. And then we can also begin to have dialogue and conversation about sickle cell disease and why it's necessary and important to understand how devastating it could be from the trait perspective, but also how devastating it could be from the sickle cell disease population perspective. Because we know an average individual with sickle cell disease, if you're male, only live to 42 years and 45 years on average if you're a female. And so I hope that you all would vote favorably for this bill to encourage our community to dig into their health history and then to plan appropriately for family planning, because it is very important. And so thank you so much for the opportunity to speak, and have a wonderful day. Thank you.
You're very excellent witnesses. Are there any questions? All right, you taught us a lot. Thank you.
Thank you, Madam Chairman. Thank you, committee.
All right, that ends the testimony on that bill. We're going to Senator Reedy, Senate Bill 689, Pharmacy Benefit Managers Prohibited Actions. Senator, we're going to bring up your first two witnesses, James Doyle and Sanjay Rayathar. Theta. Okay, Theta.
Thank you, Madam Chair and members of the committee. I'm going to make an adjustment here quickly. Thank you. We're on 689. There we go. Thank you, Madam Chair, members of the committee. Thank you very much. Senator Justin Reedy here for the record, presenting Senate Bill 689, Pharmacy Benefits Managers Prohibited Actions. Senate Bill 689 is legislation that would prohibit PBMs, pharmacy benefit managers, from engaging in practices that take unfair advantage of independent and community pharmacies. PBMs use their unfair advantage to rack up tremendous revenues and profits, and their superior bargaining position allows them to steer business and offer more favorable terms to pharmacies that are affiliated with themselves as PBMs. Just recently, PBMs recorded third quarter 2021 revenue in excess of $39 billion. And at that point in 2021, at the end of the third quarter, they had year-to-date revenues of $153 billion. I know this committee has heard a lot about PBMs over the years, and we've been working on some moderate changes here and there, and I think there's been some good progress. I bring these bills because I'm concerned about, I'm proud to represent a number of independent pharmacies in my community. And independent pharmacies are really the bedrock of a lot of small towns and rural areas. And I know they're also an important part in places like Baltimore, in communities and neighborhoods that don't have access to chains. I'm not I'm not against chains by any means. Everybody, there's a role for everybody. But PBMs really have been a major part of why, of the struggle that our independent pharmacies have been facing in communities like mine. So this bill would specifically prohibit 4 practices that I'll lay out for you. There'd be it would prohibit spread pricing, which is when a PBM is paid by the drug plan sponsor at one price, but then reimburses the pharmacy by a lesser amount, for a lesser amount. PBM pockets the difference even when they don't take possession of the drug. So there's nothing really involved, but they're pocketing the difference. They had nothing to do with dispensing the drug. This practice has already been banned in a number of states. Senate Bill 689 would also, currently, PBMs control which pharmacies can become participants under a drug plan. They have vested interest in promoting their own affiliated chain pharmacies, and that's to the exclusion of our independent pharmacies, our small businesses. This bill would say that any willing pharmacy or any willing pharmacy or one that agrees to the conditions of the plan should be permitted to join the plan. And 26 states have had this any willing pharmacy provision put into their law. Third, it would keep PBMs from setting different copay amounts when they oftentimes will set a different copay amount for a PBM affiliated pharmacy versus one that is not. And I believe that's not good business. That's an issue for that's an unfair practice, and we ought to restrict that. That's in the bill. And then finally, we're going to restrict mail order. We're going to restrict PBMs often require specific drugs be ordered through a mail order pharmacy, and of course those pharmacies are typically affiliated with the PBM. So this practice steers them again to PBM pharmacies. We want to end that practice as well. So the goal of Senate Bill 689 is to end these predatory practices that harm consumers and independent pharmacies. I would urge a favorable report on Senate Bill 689. There's a technical amendment that's in your packet from the Maryland Insurance Administration that we've worked out with them, and then I believe the Maryland retailers have an amendment that they would like that I'm fine with, that I would support as well. I understand this is a dense bill. This is a big, sort of a heavy lift in a lot of ways in the past, but I think the time has come for us to take real, serious, strong action, continue the progress we're making to make a more fair climate for our pharmacies across the board, and to continue to put PBMs into the right posture as being more regulated than they are now. And so with that, Madam Chair, I'd be happy to answer any questions, or I'd suggest turning it to the panel and let them proceed.
Senator Kramer has a question.
Thank you, Madam Chair, and thank you, Mr. Bill Sponsor. If I'm reading this correctly, this bill would regulate business, is that correct?
It would seek to regulate a business that is regulating the industry with no regulations on themselves.
So we're
A
creating...
monopoly, if you will.
We're
which I'm
creating new regulations for a business with this bill, is that accurate?
I would say we are creating guardrails for how we operate correctly in a
It
heavily
appears to be-
regulated space.
It appears to be new regulations, and maybe I'm mistaken, but it appears that we're creating business regulations that would make it harder for a business to operate in the state, but I guess I'll wait and hear what these good gentlemen have to say. Thank you, Madam Chair.
Let me just ask the sponsor. You would agree that the PBMs don't add anything of value in the healthcare system right now, do they?
I'm sure they would argue that they do in some way, but I've struggled to find how to articulate the value.
Okay,
So I agree with you. With your question, I would say that that's correct.
okay. All right, thank you. We'll go to your witnesses. You have 2 minutes each. Who would like to go first?
Thank you, Madam Chair. Jim Doyle on behalf of the Independent Pharmacies of Maryland. And I don't want to repeat what the senator has already said. But there is, at the present time, a real imbalance between the power of the PBMs and the power of the community local pharmacies. And this bill seeks to address that. And you don't have to take my word for that imbalance. In my written testimony, you'll see a large number of quotes from the Attorney General of Maryland, who has weighed in on this subject as a matter of record on behalf of the state of Maryland in 2 significant federal court decisions. And you can read those for yourself. I'm not going to take the time to go through them. but he talks about the superior bargaining power of the PBMs. He talks about the steering of business to PBM affiliates, and he talks about the unfair advantage in dealing with independent pharmacies. The other thing I would like to point out quickly is, again, the unfair advantage that PBMs have shows quite clearly in the revenues, the staggering revenues that PBMs are producing. And the senator was actually a little below the actual facts. Just one PBM in Maryland, CVS PBM, had a revenue last year of $153 billion, up 8% in 1 year. Staggering amounts of money. That's just one PBM. Now, what this bill wants to do is to deal with spread pricing. The PBMs will say, well, this is just risk mitigation. We're taking a risk either way. That's not true. What risk is being taken by the PBMs when one PBM, for example, is making $153 billion a year in revenue? Is that any risk that's being taken by that PBM? In terms of any willing pharmacy, that's the other point I wanted to get to. I will just say that the negotiations that take place right now under the current system, which they will talk about being a negotiated system, when CVS PBM is sitting down at the table negotiating with CVS Pharmacy to lower rates, supposedly, what genuine negotiation does anybody believe is occurring in this place? This is like me to go and buy a car, and the car owner sits at one side of the table, and the dealer salesman sits at the other side of the table and negotiates the price that I'm going to pay for the car. That's not negotiation. And that's what's happening now, and that's why we need any willing provider. Independent pharmacies are being kept out of this process. They need to be allowed in as long as they maintain the same terms and conditions and are willing to abide by that. Thank you.
Okay, thank you. And Mr. Harper?
Thank you, Madam Chair and members of the committee. My name is Sanjay.
Yes.
Yeah, it's movable. There you go. Yep.
Sorry.
You can pull it even closer. Pull the
I'm good.
base of it closer.
Can you hear me now?
Yeah,
Okay,
but so that you're more comfortable, just pull the whole base, yes.
There you go.
thank you. Thank you. So my name is Sanjay Raitata. I'm a pharmacy owner in Anne Arundel County. And I want to talk about the spread pricing and how it negatively impacts pharmacy as well as the customers. Because the spread pricing in the end ends up costing the customers more, and which also costs the employers more money. Now, about 3 or 4 years back, I think there was a study in the state of Maryland where they determined that in the Medicaid system, it's a $72 million was the spread pricing the CVS Caremark charged the state. Now, that comes down to roughly, based on about 1,000 to 1,100 pharmacies that there are that I am aware of, $60,000 to $70,000 per store is what they're charging, a fee, which essentially is going to their pockets, which is either going to the customer or going to the pharmacy, which impacts the level of service a pharmacy can provide, which really impacts the bottom line, so amount of people we can have to service the customer. So that's one piece. I think Jim talked about it, and like spread pricing also creates an incentive for the PBMs to steer customer to their own, pharmacy that they own or they are partners with, or their own mail order. As we saw last year with COVID, the mail order was not the best, approach for most of our customers, because medications often didn't make it. Medications often were sitting in a mailbox, and they got destroyed and so on. And the independent pharmacies really stepped up to the plate, taking care of the customers. We delivered, we offered curbside delivery, all of those pieces. So it's very important that independent pharmacies stay viable in the future, and the spread pricing is not going to allow that. Thank you.
Thank you. All right, we're going next to the following witnesses: Gerard Herpel, Shireen Joseph, Aliyah Horton, those people are here. Come on up to the table. And then we'll add also Kaylee Locklear from the Maryland Retailers, who is favorable with an amendment. All right, you have 2 minutes each.
Let me go first.
Just state your name and begin.
Thank you, Madam Chairman. I'm Gerard Herpel. I'm a owner of Deep Creek Pharmacy and also a member of the Epic Buying Group. We've said for years that there needs to be transparency and regulations in the prescription marketplace because of the policies that are played with the payments of pharmacy claims. This bill regulates many of the issues that have plagued independent pharmacies and given control of the market to a few large PBMs. These are included too, we've already discussed some of these, restrictive networks, mandatory mail order, spread pricing, differential co-pays, slow credentialing, retroactive fees. And this has made it nearly impossible for some of the pharmacies to survive in the current marketplace. By supporting this bill and its requirements for PBMs, you will help level the playing field and give the consumers the power to choose that best fits their needs. The PBMs will argue that they are saving the payers on the cost of prescription benefits by limiting the network. But does this truly help our patients, your constituents, on their cost? I see many times that a patient will come in who have large co-pays and are actually subsidizing the PBMs via the GER fees. And that'll be discussed later. But the GER fees are taken back from the patient's co-pays. This is especially egregious when a patient or your constituents has a high deductible plan. In essence, this is an extra premium being paid at the pharmacy counter by the patient. The PBMs, in essence, are double dipping. The bill helps patients by allowing to choose their pharmacy to participate. And we have said many times that allowing more pharmacies to provide service to patient doesn't increase costs, but does increase access to the consumer. Spread pricing is not like buying a shirt, because the buyer of the shirt is not telling the maker of the shirt how much they can charge the seller of the shirt. Just remember that. We respectfully ask for the committee to support Senate Bill 689. Thank you.
Thank you. All right, you want to go next?
Madam Chair and the members of the committee, my name is Sharon Joseph, and I'm here representing the Independent Pharmacies of Maryland. First of all, I would like to thank this committee for your past support and your continued support, which gives us the courage to be here today. Past 2 years of the pandemic has proven how vital an independent pharmacy is to the community. We were front and center in running vaccine clinics, providing vaccines to our elderly in their homes. These were people who could not physically make it to the mass clinics, reassuring constituents on the vaccine safety, and counseling parents on the right choices. When the large chains in our community sometimes had to stay closed during the pandemic, we buckled up and stayed open longer hours to accommodate the needs of these constituents. Our only regret was not being able to help those whose right to medications were locked into a chain pharmacy or a mail-order pharmacy. Yet we gave them bridge supply at no cost while they waited for the chains to open back up. Last week, a PCMA representative was testifying in the House that regardless of what legislation is passed, the PBMs are not going to lose money. Yet the same PBM is forcing independents to lose money on more than 50% of our prescriptions with one-sided contracts and below-cost reimbursements. I wish they could show us the magic of sustaining a business on a 35-cent dispensing fee. Every time we ask for a regulation, all they have to say is premiums will go up. But a recent NCPA study shows that this argument is not true. In fact, in states that have adopted laws protecting patients and local pharmacies, they found slower premium growth and in some cases premium reductions. In Hawaii, in Louisiana, California, West Virginia, in Georgia, premiums went substantially down after the state banned forced mail order. Same results in Louisiana and Tennessee where prescription prices went down while the national average went up. All we are asking for is a level playing field where we can compete on providing the best service. As we speak, many of our members are considering to close their stores. And if this trend continues, most of us seated at this table today are headed that way as well. So we humbly ask for a favorable report on SB 689. Thank you.
Thank you. All right, and Mayor Kelly.
Good afternoon, Madam Chair and honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Association of Chain Drugstores. And I just want to start by saying that we are fully supportive of efforts to protect our brick and mortar pharmacies by ensuring PBM transparency and improving patient access to a consumer's chosen pharmacy. In reference to what PBMs can do in the bill, I would direct you all to page 4 after line 8, and you do have an amendment before you, as we want to ensure that a loophole is closed in the bill with regard to copay. And we've been working with proponents, sponsors, thank you, Senator Reedy, and DLS to craft language, and finally settled on language that actually currently exists in West Virginia. So let me provide you with an example of how this could play out as the bill is currently written. Say a patient's preferred prescription copay is $30 for a 30-day supply. A PBM can actually allow a member to get a 90-day supply of drug at mail order for a $30 copay. But they can still only allow a 30-day supply of that same drug at retail for a $30 copay. So in essence, the PBM who does this would still be compliant with this legislation if it becomes law, because this bill only says PBMs cannot charge different copays to retail than they do at mail. But what it's missing is it's not based on the actual daily supply. So with that said, we urge a favorable report and the adoption of the amendment before you. Thank you.
Thank you. Are there any questions of this witness? All right, thank you very much. Okay, we're going next to the unfavorables, Camille Fetch, Michael Johansson, Kimberly Robinson, and Matthew Celentano.
Thank you, Madam Chair. I'm Mike Johansson, if I can go first, if that's okay.
That's fine.
Thank you. Mike Johansson on behalf of the Pharmaceutical Care Management Association. Not sure how your system works, but I do have a handout that I provided. I want to walk through something. This bill is being described as a PBM restriction bill. Can't let the PBMs do this. PBMs are unfair. I have a sample of a basic employees benefit guide, happens to be Montgomery County, but in Ohio. Didn't want to pick anything too close, but trust me, you have these in every one of your jurisdictions and local school boards. This health benefit plan, as described by Montgomery County, our medical plans are self-funded. You read that right. The full cost of our medical and prescription drug benefits is paid by Montgomery County taxpayers and you. The costs for that are not paid by Anthem, the insurance company in this particular case, or by their PBM, which is related to that same entity. Okay? In this document, which they describe to their employees, the rationale, how they got to this health plan and how they're trying to save cost, it says, under our prescription drug coverage, you must fill prescriptions for maintenance medications either at a 90-day retail pharmacy or through the PBM mail order. If you fill maintenance medications at other pharmacies, the cost will not be covered at all under your plan. With regard to specialty drugs, to ensure that your medications are handled and administered correctly, you must fill these prescriptions through Ingenio Rx, which is the one specialty drug provider. Okay? Do those sound like the words of the PBM? Those are the words of the county officials that negotiated, solicited, and procured a PBM contract. To the point of whether or not PBMs add value, I would ask you to ask DBM why they have a PBM contract for your state employees plan. DBM could just pay claims. You don't have to have anyone help you negotiate lower prices. This bill limits health plan sponsors, which are the same governments that have employees, that have labor and collective bargaining units that sit on these selection panels and make these decisions. The PBMs don't make up these rules. They'll do the rules if that's what the health plan sponsor wants. You want a mail order only plan? Sure. You want a specialty that's only one pharmacy and it gets mailed into a local pharmacy or straight to the home? Sure. Do you want us to have a narrow network where we only have some chain pharmacies in, some out, and we only have some independents in and some out, and we can deliver you a lower price? The plan sponsor says yes or no, and that's what the PBM does. This bill would eliminate all those choices by the health plan sponsors. Thank you.
Are there any questions? Okay, Kimberly.
Good afternoon, Madam Chair, members of the committee. Kimberly Robinson, Regional Director for Government Affairs for Cigna and her subsidiaries, in respectful opposition to the bill. Just going to start from where Mr. Johansson left off. This bill gets to the relationship between the PBMs and the companies and the counties and the states who is purchasing their services. And at the end of the day, as Mr. Johansson said, the PBM can design the plan any way that the purchaser wishes them to. If you don't want mail order, you don't have to purchase mail order. No one's required to. It's a choice that the purchaser makes. If you don't want to use specialty pharmacy, you don't have to use specialty pharmacy. It's a choice that the purchaser makes. And that purchaser is your local county government, your municipality, the state of Maryland, every large business in the state of Maryland, who for the first time would be regulated by this bill because it attempts to expand its scope to include self-funded employers in our state, which we historically have not done. And to Senator Kramer's very astute point, this bill is going to have an impact on businesses in our state who unfortunately aren't accustomed to looking at these bills. Your county governments aren't looking at this and understanding that things they do today, you're going to take away from them as choices because they're not your typical constituency on these bills, and you've never made this reach into their business before. When we talk about spread pricing, it is a mechanism for how the PBM is being reimbursed. You can do it on a flat fee. You can do it on a per member, per month basis. Spread pricing is essentially a per prescription basis. And so depending on how many prescriptions are being filled is going to impact what the reimbursement is to the PBM. The purchaser, however, is choosing how it wants to fund its relationship with the PBM. It is not mandated by the PBM that any purchaser use spread pricing as its mechanism. It's a choice that the purchaser is making. The bill also goes on to make decisions about copays. Copays are decided by the purchaser, who is deciding how much of the benefit they're going to fund for their employees, how much of the cost they're going to assume. They use copays, as we do in all health products, to manage the ultimate cost to the purchaser. There's a couple other things that this bill does that I'm going to run out of time. I would invite you, Senator, to ask me about the values that PBMs bring. I respect you very much. I'm disappointed that that's your perspective. I don't know the committee's ever had a briefing on really what PBMs do, but I would love to answer that question for you.
Answer that question.
Thank you for the question, Madam Chair. So here's the thing. There is a time when health carriers were going out and attempting to negotiate their pharmacy networks and provide the pharmacy benefit in-house to that carrier. So Cigna just for Cigna, CareFirst just for CareFirst, Aetna just for Aetna, Anthem, Kaiser, et cetera. The challenge becomes, in the world we live in, when it comes to how drugs are priced, leverage makes a difference. And I know that independent pharmacists resent the leverage that they feel like PBMs have over them. We resent the leverage that pharma has over us. And so what has happened is that in order to benefit that plan and its members, its insureds, what happened was they discovered that it made more sense to have a third party administer those benefits, who, instead of negotiating those drugs just for the 6 million people in the state of Maryland, are now able to negotiate them for every person they're covering in the United States. And so by creating that volume, creating that size, you are now gaining leverage to negotiate better prices with the people who are ultimately setting the prices for the drugs, the ones who are deciding what we're going to pay for insulin and everything else. And that has become a benefit to those who are providing these benefits. It's not by accident that the state of Maryland, that Baltimore County, that pick any large business in the state of Maryland is using a PBM to provide their benefits. It's because they know it would cost them more money to do it on their own. So it sounds like a lot of revenue that the PBMs are receiving. Again, we're doing this on a national basis. That's a national number. It's not what we're earning in the state of Maryland. And we live in a country that in 2019 filled nearly 5 billion prescriptions. So it's not as though this is not a service that is sort of size to what is happening in our country, we fill a lot of prescriptions, we manage a lot of benefits, and so there's a relationship between how that happens if you look at the number of people that we're covering and the value that our clients would tell you we bring to them because we are helping them provide these benefits to their members and employees in a way they know they can't do on their own. They very much value our services, and that's why they choose to use them.
Okay, Senator Reedy, the bill sponsor, has a question.
Thank you, Madam Chair, and thank you all for being here. And I think the comment about not providing any value was maybe a little too pithy, and I sort of thought about that as I was walking back here, because obviously
That's fair.
there's a role for things. I understand the role to some extent. I know historically there was a need to figure out how to get rising costs under control, and that's still something that you all would say is what you provide, and that's a part of the process. Can I ask you, I mean, some of the points you raise, I understand whether I disagree completely with how you're saying it or not. I understand the point of view. I think the question that, from looking at it from the pharmacy side of it, on any willing pharmacy, why can there not be, if someone's willing to meet, if a pharmacy is willing to meet the requirements in the plan that you've talked about, how you try to keep the cost low for the client, why is there an exclusionary policy that doesn't allow them to do that?
Do you want to answer it, Mike? You want me to answer it?
Either one of you is fine. Yeah.
Thank you for the question, Senator Reedy. So here's the thing with any willing pharmacy. One, Maryland has considered any willing provider bills of various sorts over my entire 20-year career before this body, and has routinely rejected them because there is an incredible body of evidence that shows that any willing pharmacy laws, although while not obvious on their face, actually do increase costs. In fact, the body who's done most of the studies around any willing provider laws and this fact is the FTC, who actually has published specific to pharmacy its own paper in the last 4-ish years, and I think Matt might know what it is exactly, that speaks specifically to why they believe that any willing pharmacy laws are problematic when it comes to its impact on healthcare. That's not to say in any way we are looking to specifically exclude pharmacies. I know there's a lot of conversation about PBMs who own chain pharmacies. Every PBM does not own a chain pharmacy. But what happens instead is, just like with any provider network, so take your PBM thoughts off and just think about how we do healthcare generally. Plans have networks. The goal of the network to make it beneficial for the provider is to drive volume to select providers because it gives them the opportunity to give us a better price. So instead of your doctor charging us their bill charge, they cut us a break because what we do in exchange is we push more people in their doors. And so by doing so, they're willing to give us that discount because they're going to get the increase in volume. And so that's what networking generally in healthcare is designed to do.
It's a good answer, and I appreciate it. And Madam Chair, I'm going to ask one follow-up, and I know we can't spend forever here talking. You do understand the frustration, the concern of, you're saying not every PBM owns a pharmacy. I understand that's true. There doesn't seem to be a lot of transparency, and there's a lot of concern about, though, the self-dealing aspect, which was brought up in our proponent's testimony. I don't know if you want to speak to that, but when you have, CVS dealing with CVS, there's a lack of opportunity in that for other providers to be involved, and of course you're going to get a better deal with a chain. So at some point, if you're saying we're going to do this all for a better deal, we are going to force out independent operators because they can't do the volume, not because they can't necessarily meet a price, but because they can't do the volume. I don't know if you can comment on that, and that's my last question.
I'm going to let Mike respond to that one.
So there actually was some interesting data from the Health Department published in January 2020. I think the proponents referenced the same report. It looked at the Maryland Medicaid market for the MCOs, all of whom use PBMs. They don't all use CVS, by the way, which was, I think, suggested. And, of course, Medicaid is 25% of the population. It's $15 billion total program, so it's a big sample size. The reimbursements to the chain pharmacies as a group were less than the reimbursements to the independent pharmacies. And some would expect that would have been expected because of the fact that chain pharmacies have larger volume purchasing power. They're willing to negotiate contracts for less. The independents actually were reimbursed more. When you get outside of the one PBM that actually owns retail stores and you look at the connections between PBMs and specialty pharmacies, here's where you have the very most expensive drugs. You have the requirement for coordinated medical integration with the delivery of those drugs and their use and how to adhere to them. And that's a situation where, you know, the PBMs are very upfront with the health plan purchasers. They, during the bidding process, they describe if we use the pharmacy that we have a relationship with, we can guarantee these prices. If you want us to use different specialty pharmacies than others, you know, the pricing's gonna be different because those costs are gonna be different. And the interesting thing that I found about this, and it is in my packet if you guys take a look at it, the health plan sponsors, which are county officials and their employees or states or whatever, they hire consultants to help them negotiate these deals. They hire consultants not only to help pick the right PBM in the competitive process, then they hire consultants to go back and audit the PBMs themselves to make sure they're delivering on the promises. And there's one example in the packet that I gave you. They hired a consultant to specifically look at specialty drug spend, which was within one of these kind of, you know, related pharmacies. And they went in there and they made additional recommendations with respect to that related pharmacy and made additional recommendations for which drugs to put into specialty and which to not, and how to change the healthcare delivery side, all in an effort to save more money. So I think the frustration that we hear from the proponents often is the PBMs are just unilaterally making these changes and they make different decisions on different plans, and we never get back to the point that our boss is the individual health plan sponsor. And we're accountable to them, and their charge to us is try and find a way to save money because we don't want to pay for high prescription drug costs.
Okay, well, there are a lot of us worried about the extent to which we're losing independent pharmacies, though, in Maryland. I mean, there are whole towns and villages with none. Okay, thank you. And Matthew?
Thank you, Madam Chair. Members of the committee, my name is Matt Celentano, here today on behalf of the League of Life and Health Insurers and AHIP in respectful opposition to Senate Bill 689. My two colleagues to my right have covered a lot of the ground that I was going to cover, but I'll just make 2 points on the behalf of the carriers. We think the main point is this is not really a PBM bill. It's a carrier bill, as they're the definition, they're the purchaser in the bill. And the only entities being impacted here are health plans and the state health benefit plan. The prohibition on spread pricing is essentially for health plans only, and with no plans here today asking for it, we're not sure why the bill might be being considered to be moving forward. Also, for perspective, it's been shared with me that a lot of the plans actually seek out spread type arrangements as they can get they can maximize the savings for their groups. The other point I wanted to talk about was the any willing pharmacy provision. Ms. Robinson covered a lot of it already, but I do want to point out or point to the 2015 FTC study, which is a letter to CMS. The FTC made the point that, quote, any willing pharmacy provisions threaten the effectiveness of selective contracting with pharmacies as a tool for lowering costs. Requiring prescription drug plans to contract with any willing pharmacy will reduce the ability of plans to discuss discounts based on the prospect of increased patient volume and would thus impair the ability of plans to negotiate the best prices with pharmacies. I'll just stop there, but we respectfully request an unfavorable report on 689 as that we think it's going to increase cost to Maryland insured customers. Thank you.
Okay, any questions? Okay, and then our final witness is, let me find you. Okay, state your name and go ahead.
All right. Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. For the record, my name is Camille Fesh, here representing PCMA, the Pharmaceutical Care Management Association. To paraphrase what Mr. Celentano said, my three colleagues, not the two colleagues to my right, have already covered a lot of the topics we're covering. So I just want to dive a bit into pharmacy networks and how they encourage competition and promote access. As Ms. Robinson mentioned, creating a specific network helps create competition, and that means that there are pharmacies, like other providers, doctors groups, et cetera, that are willing to give lower prices, thereby saving money for the ultimate patient, because they will get more volume and they'll have patients that are encouraged to go to them, as opposed, and then for that they give a lower price, as opposed to any willing provider, where if anyone shows up, it will prevent a PBM from perhaps excluding a pharmacy in the very, very rare occasion that there's a bad actor. It also means that there's less oversight from the PBM, understanding what the pharmacies are doing, the value of the quality and the enhanced level of services. And it also helps reduce fraud, waste, and abuse in the rare instances that those occur. And all of those tools are extremely important to not only the PBM, but more importantly, the health plan purchaser in order to help keep the cost of prescription drugs lower for the patients that receive them from the pharmacy. With that, we respectfully oppose Senate Bill 689. Thank you very much.
Thank you. Are there any questions? All right, thanks so much. We're going next to Senate Bill 690, Senator Reedy, Pharmacy Benefit Manager's definition of carriers, ERISA, and purchaser. And let me call up your initial panel. James Doyle, Aaliyah Horton, and I'm going to call up the favorable with amendment, Gerard Herpel. If those people are here, you may be seated.
Thank you, Madam Chair. Members of the committee, Senator Reedy for the record here to present Senate Bill 690, Pharmacy Benefit Managers, definition of carrier, ERISA, and purchaser. This bill is dealing more making it clear in the law about recent decisions of the Supreme Court and how it relates to whether ERISA PBMs can be subject to regulation by our insurance code. This bill will subject ERISA pharmacy benefit managers to all the provisions of the insurance code of the state set out in Title 15, Subtitle 6. Currently non-ERISA PBMs must comply with the provisions of our insurance code in Title 15, Subtitle 16, while ERISA PBMs have been exempted from many of those provisions. And under this bill, all the provisions of the insurance code would apply to ERISA PBMs. It carries out the broad state regulation of ERISA PBMs as permitted by the decision of the U.S. Supreme Court in Rutledge versus Pharmaceutical Care Management Association from 2020. Rutledge held unanimously that states have broad authority to regulate ERISA PBMs. Supreme Court held in this landmark ruling that ERISA preemption did not apply as long as states did not require payment of specific benefits or set rules for determining beneficiary status. In enacting legislation in 2021, the General Assembly carved out or exempted ERISA PBMs from several sections of Title 15, Subtitle 16 of the Insurance Code because of claims by the PBMs that Rutledge's decision was very limited and did not allow for the full application of our code. Because of these claims, the General Assembly expanded some regulation to ERISA PBMs but exempted other provisions. So to clarify the issue, the General Assembly specifically required an MIA study to clear up the issue about the scope of Rutledge and preemption. The resulting MIA study completely rejects the idea that ERISA PBMs are preempted, that ERISA preemption would prohibit or restrict full application of Title 15 to ERISA PBMs. Quoting from their study, it is the view of the Maryland Insurance Administration that should the legislature elect to make all of the current provisions of Title 15, Subtitle 16 applicable to PBMs when contracted with an ERISA plan, the enforcement of those laws by the MIA would not be preempted by ERISA. So this bill also implements the position of record of the state of Maryland taken by Attorney General Brian Frosh in court filings, which calls for broader regulation of PBMs. As stated in the amicus brief, which we've included, joined by Attorney General Frost, state regulations of PBMs is necessary because PBMs have the potential of harming pharmacies, consumers, and states. And Rutledge reaffirmed that regulations do not force plans to adopt any particular scheme of substantive coverage are not preempted by ERISA. So I have a lot more in my testimony. I will not go further into the legislative dialogue of the Supreme Court case, but we brought this bill so that we can sort of finish the job of what was started in 2021 relative to ERISA PBMs, and I would love to turn it over to my panel to discuss this issue further.
Thank you. Are there any questions for the sponsor? Okay. All right, then we'll go to James Doyle.
Thank you, Madam Chairman. Jim Doyle on behalf of the Independent Pharmacies of Maryland. This bill should have been passed completely last year. It was not because there were misinterpretations of the Rutledge decision by the PBMs, questioning about how far Rutledge went. So as a result, the General Assembly passed essentially half of the law that Rutledge would have allowed in terms of regulation, and withheld it on, say, roughly another half of the law. But the General Assembly then wisely said, we want to get this settled. We want the Maryland Insurance Administration to study the issue of the extent of Rutledge, which it did. And it came back and it completely rejected the arguments of the PBMs that Rutledge did not allow the complete regulation of ERISA PBMs, just as it allows the regulation of non-ERISA PBMs. So all we're trying to do with this bill is to equalize the two. Whether you're an ERISA PBM or a non-ERISA PBM, you're governed by those same insurance provisions in the insurance code. And that's what this bill will do. We'll put them all under the same regulatory regimen. Every relevant legal authority that you can look to, whether it's the Maryland Insurance Administration, whether it's the Attorney General of Maryland, whether it's the first case that came after Rutledge out of the Eighth Circuit Court of Appeals, the Webby decision, every one of those has rejected the arguments of the PBMs and said that, yes, the states have the authority to regulate ERISA PBMs just as they regulate non-ERISA PBMs. Thank you.
Okay, thank you. All right, and let's go to L.E.R. Horton.
Thank you, Madam Chairman. Chairperson, sorry. Gerard Herpel, Deep Creek Pharmacy, owner of an Epic Pharmacy. We've been dealing with the repercussions of federal ERISA laws in Maryland as they related to PBMs for many, many years. The state, this committee, House committee have always taken the PBM's assumption that their business practices were always protected by the ERISA laws, and that anything that we came in front of a committee, any bills that came in front of the committee, were only going to affect 20 to 25% of the population of the state. Rutledge has changed that. After the decision, we've come down here, we tried to work with the committee to remove, and as Mr. Doyle said, we got half of legislation. You will continue to hear from PCMA that this is not a settled law, but in the most recent case from November of 2021 in the Eighth Circuit Court, further upheld the ruling in a North Dakota case. The name of that case was PCMA versus Webby, if that means anything. The ruling went on to even further in rebuking the claims that PBMs cannot be regulated by allowing North Dakota's law to apply to Medicare Part D plans as well. The clear message from these decisions is that the state legislatures, like this one right here, can most certainly regulate the actions of PBMs, no matter what you may hear from PCMA today or going forward. This issue of ERISA preemption has been settled, and they can no longer hide behind an almost 50-year law. In this committee hearing, well, I've already gone through that, so let's just say thank you, and we would like your support of this bill.
Okay, are there any questions? Okay, thank you very much. Okay, we'll go to the next group. Okay, Gerard Herpel. Oh, wait a minute, we just heard you. Okay. Camille Fetch, Michael Johansson, Kimberly Robinson, and Matthew Celentano, unfavorables. Make a panel, and you have 2 minutes each.
Thank you, Madam Chair. Mike Johansson on behalf of PCMA, we oppose this legislation. I think they accurately described it. This intends to expand existing state regulation just on PBM services to health plans that are offered by all your local governments, school boards, employers in Citus in Maryland that are in the small group market, your individuals on the individual exchange, and larger employers that are cited here that are fully insured. The bill doesn't say that their health plans should be regulated. It just says their PBM plan should be regulated. So what's being suggested to you is, let's just make sure they can't use tools to reduce prescription drug costs, because we don't think that makes sense. It's a little bit of a strange argument to say, we want to regulate you, Prince George's County School Board. We don't want you to have a mail order preference. We don't want you to have a specialty pharmacy preference. We want to basically say you can't use those tools anymore to reduce your prescription drug costs. That's what this bill says. It says the same for those larger employers that aren't regulated today either. Let me mention, you asked, Madam Chair, we did submit some information on the number of independent pharmacies. I understand the concern. We've heard it a lot about the number of independent pharmacies. The data, however, consistently shows that more pharmacies open than close, even in the state of Maryland, that are independent pharmacies. The Health Department did a 3-year study that was released in 2020. Again, in every county, more independent pharmacies open than those that close. I'm not going to suggest there aren't some that don't close, but across the country, in aggregate, more are opening than closing at this time as well. Thank you.
Are they remaining open?
Well, I think that's the point, right? So some are opening and some are closing. I think it's a small business. I think it's probably a very difficult small business. We noticed even during the pandemic that some of the chains closed because they couldn't find staff. So I think there's been a shakeup for a number of reasons.
Okay. All right, Kimberly?
Thank you again, Madam Chair, members of the committee. Kimberly Robinson, Regional Director of Government Affairs for Cigna, respectfully in opposition to Senate Bill 860, or 690, thank you, 690. As Mr. Johansson said, this bill, by expanding to ERISA plans, will have a pretty significant shift for businesses and local governments in the state of Maryland, who, again, are not accustomed to the state regulating their benefits. And while it's being done through the PBM, it will have the effect of regulating the pharmacy benefits in many ways that are offered by businesses who are not typically before you on these issues. Many of them are before you on other things, but they're just not accustomed to having to worry about what the state is doing about their benefits because they are accustomed to it being protected. And while the Supreme Court decision did open the door, I think that there's a healthy space to debate how wide that door is opened. While our insurance commissioner's office has taken one view, there are many states in the country who have taken the view that it is a much narrow decision. I think there'll be a lot more to come about that in years to come. And so what I would encourage this committee to do is to be thoughtful before you were to make this move. I would encourage you to talk to the HR managers of your own jurisdictions who, while they are not in this room, I suggest to you would be very surprised to know that you were going to fundamentally change how they can negotiate their pharmacy benefits by expanding this law in the state. Sometimes I think the principle is just because you can, the question is should you? And I think in this space to do so without consulting with those businesses who are really the ones impacted, because it's not the PBMs. Again, we can sell our products in a myriad of ways. It's the people who are choosing to purchase them who you would limit in taking this expansion of our law. And I just don't think that they're fully aware. As a person who does this work regionally, I will tell you that several of our neighboring states have either opted not to go down this road, Virginia, for instance, who chose not even to study whether or not they should expand under ERISA. Their business community stood up and said no because they happened to pay a little bit more attention a little bit more quickly. Or West Virginia, who, while they've made this expansion, just got a flood of letters from businesses this year who were starting to pay attention and were very concerned, which included unions, manufacturers, and chambers of commerce. And so for that reason, I would respectfully request an unfavorable report.
Okay. Are there any questions? All right, we'll go to you, Matthew.
Matt Celentano here today on behalf of the League of Life and Health Insurers and AHIP in opposition to Senate Bill 690. Thank you, Madam Chair and members of the committee for the opportunity. For decades, state laws relating to health benefit plans, including prescription drug benefits, have been only applied to fully insured health plans subject to regulation by the MIA, not plans exempted from federal ERISA law. We understand the Rutledge decision has sort of changed the landscape and the discussion, but it doesn't change the fact that proponents are now trying to mandate changes in plan design, and that is a key point. By extending the provisions of prior PBM law structure to self-insured plans, these proposals will restrict the opportunity for health plans to reduce pharmaceutical costs in the space to their members and to the plans that hire them to actually administer the benefit. We do believe, and I agree with Ms. Robinson, this will come as a shock to a lot of these businesses that have no idea that these discussions are taking place, and we'll see sticker shock in the drug space in the near future if this bill passes. We urge the committee to gather stakeholders in the interim, including the funded entities that might be blindsided by the impact of this bill and try to work through the cost impacts for discussion in the future. So we respectfully request an unfavorable report on Senate Bill 690.
Okay, thank you very much to you guys. And, let's see what we're going to next. All right, that's the end of that testimony. All right, we're going next to Senate Bill 823, Senator Kramer, Pharmacy Services Administrative Organizations and Pharmacy Benefit Managers Contracts. And let me call up your panel. Matthew De Loreto, Gerard Herpel, and David Kahn.
They do show you as unfavorable, by the way.
I changed it.
Come on up.
Okay, let me call one other person. Let me call also Camille Fish. Okay, you're there. Okay.
Crowded table.
Do we have, well, we'll call you as soon as these are done. Okay. Your name was what?
Last name's Herpel.
Okay, okay.
Well, good afternoon, Madam Chair, Mr. Vice Chair, members of the Finance Committee. Ben Kramer here to introduce Senate Bill 823 and colleagues. This one's going to be easy, short, and sweet, so I'm not going to take up a lot of your time because there's no opposition, so there's no reason for me to usurp the valuable time of this committee. Senate Bill 823 has one amendment, and the bill as amended is simply a technical fix for reporting issues that relate to a bill this committee passed 2 years ago. And with that, Madam Chair, you've got it. So I'll turn it over to the panel.
Good afternoon, Madam Chair, Mr. Vice Chair, and members of the committee. For the record, my name is Camille Fesh, here on behalf of PCMA, the Pharmaceutical Care and Management Association. We are here favorable on this bill. A couple of years ago, as Senator Kramer said, we worked very hard on a bill to bring more regulation, and not just regulation, but more importantly, visibility to all links in the pharmaceutical drug supply chain. We have the PSAOs, which are, the PBMs, which are regulated by the Maryland Insurance Administration, or the MIA, and the independent pharmacists are also regulated by the Maryland government. Who wasn't regulated was the PSAOs. And those entities are entities that they contract with the PBMs on behalf of the independent pharmacists that they also contract. This huge gap really was a blind spot for both the MIA and for the legislature. So it was important that, that the legislature and the MIA have the visibility. And so when we after this bill had come into effect, the MIA had indicated they needed some technical changes added to the PSAOs. So we've asked the MIA, we support the MIA's ability to make technical changes to the bill so they can better regulate the entities that they're in charge of regulating. It also came to our attention this weekend that there is an amendment that I believe the independent pharmacists have requested, clarifying that they can receive contracts in either an electronic or a paper format. We have no objection to that. And so with that, we are favorable on this bill. Thank you very much, Madam Chair.
Okay, thank you. Then let's go to Matthew Doloretto.
Thank you very much, Madam Chair. My name is Matt DiLoretto. I'm the Senior Vice President of State Government Affairs at the Healthcare Distribution Alliance. We are the national trade association that represents healthcare distributors. As well as, for the interest of this bill, we are representing a number of non-member PSAOs as well. We are here, as was said, to voice our support for this legislation. HDA members are the vital logistics-focused link in the supply chain. We ship healthcare and pharmaceutical products to about 180,000 points of care nationwide, and a limited number of our members also provide administrative services to independent pharmacy customers referred to as pharmacy service administrative organizations. PSAOs are voluntary, administrative-focused entities that assist, as was mentioned, independent pharmacies with a number of administrative or what we refer to as back office services, and those do include their interactions with plans, payers, and PBMs. These services are offered at a transparent monthly fee. And I really want to emphasize that it is a voluntary service. Independent pharmacies do not need to participate with a PSAO, per se, to provide services to a patient or dispense medications. Although some larger HDA members offer PSAO services, it's important to understand that they are not tied to the distribution arm of that company. And like I said, there are no way requiring independent pharmacies to participate in order to provide services. As was mentioned, Senate Bill 823 targets a specific technical issue that I will allow my colleague here to explain as he is on the front lines of that issue. But we are very happy that we're all sitting up here in agreement and in support of the legislation. And we request support from you all as well. So thank you very much.
Thank you. Seeing in lights. All right. Michael?
Thank you, Madam Chair. Mike Johansson, briefly on behalf of PCMA. Yes, we support the bill as amended. I think what the bill did 2 years ago, and again, as we have these conversations about the role of PBMs, independent pharmacies, chain pharmacies, and others, the PSAOs are an important piece of this process. They, in many cases, will negotiate in bulk on behalf of large numbers of independent pharmacies, giving that independent pharmacy a larger voice when they're negotiating reimbursement prices with the PBMs. It was mentioned some of the PBMs are very, very, very large organizations. Some of the PSAOs are connected and affiliated with very large organizations. AmerisourceBergen, number 8 on the Fortune 1000, Cardinal Health, number 14 on the Fortune 1000, McKesson, number 7 on the Fortune 1000. And they may not be that big because of their PSAO business. They're likely that big because they're in the wholesale distribution of pharmacy business, which means at the same time they're negotiating with PBMs for reimbursement for drugs, they're also in the business of selling and distributing that product, and that's okay. But, when we hear about the fact that sometimes PBMs have either retail distribution channels like pharmacies or specialty pharmacies, that's often seen as a very negative thing. But when our friends at the table are here representing PSAOs and the organizations that they're affiliated with, it all tends to seem like that's perfectly fine. So the Prescription Drug Advisory Board is actually working on a report on this entire prescription drug delivery system. They've not quite done that report yet. But we hope as they look at the whole system, they look not just at the health plan sponsor at the top or the carrier, the PBM, the negotiations with the PSAO, the independent pharmacies, the chain pharmacies, but also the wholesalers and all the other pieces. And hopefully that report will be enlightening. It is a very, very complex business, but there are a lot of big names that are at the negotiating table. So thank you. We support the bill.
Okay, thank you. All right, okay, go ahead. Just state your name and go ahead.
I'm David Can. I'm a partner at Whiteford Taylor and Preston in Baltimore, and I'm here on behalf of my client, Epic Pharmacy Network. And you heard earlier from Jerry Herpel, an independent pharmacist who's an Epic board member. Epic is a PSAO, but it is a members-owned cooperative. It's owned by independent pharmacies, approximately 1,500 around the country, each of whom have one vote as a shareholder. And so it is not part of a large conglomerate. It does represent the interests of its independent pharmacy owners in their dealings with PBMs. And in my role as outside counsel, I took Epic through the process of getting PSAO registration as a result of the 2020 law. This bill is necessary because the PSAO registration was unduly cumbersome, primarily because of the provisions that required the PSAO to submit all their contracts with the PBMs. And as a result of that requirement, the MIA has required Epic to put together an addendum to the contracts that it's entered into on behalf of its pharmacies with each PBM. And that kind of turns the contracting process between the PBMs and the PSAO on its head. The PBMs really control that contracting process. Epic tries to negotiate to obtain some more favorable rates for its pharmacies. But the main value for the pharmacies is that they get to be in the limited networks that you heard about earlier today. And so this bill will correct that problem by allowing the MIA to deal directly with the PBMs with regard to complying with Maryland regulations. And that's how it should be.
Okay, thank you. Gerard Herpel? Is he here? Okay. And we'll call James Doyle, who will be favorable with an amendment. All right, you have 2 minutes each.
Thank you, Madam Chair. Gerard Herpel, member of Epic Pharmacies and the Epic Pharmacy Network, EPN. EPN, or Epic Pharmacies Network, has served Maryland independents since 1991. And we would like to express our support for Senate Bill 823. This bill corrects, and has been mentioned, some undue logistical burdens imposed by the passage of the bill that's, or the law that's in effect now. And we're greatly concerned about that burden and our ability to continue independent pharmacies to continue operating in Maryland with our PSAO EPN. Without these essential services that our PSAO provides, many would not be able to remain open to serve the patients in their communities. We are grateful to Senator Kramer for sponsoring this bill, and this will, as stated, will correct some of the most pressing logistical burdens. Independent pharmacies have worked harder than ever to support Maryland communities through the COVID-19 pandemic. We've administered tests, vaccines, boosters, provided patients with sound medical advice during an otherwise uncertain time. In addition to these pandemic stresses, the owners face complex administrative pressures that make running a business a challenge, any business. For example, pharmacies must sign and manage many contracts just to procure medications for their patients and guarantee that insurance companies will pay for them. Large chains have offices that handle all this. EPN is our large chain office, and that's what this bill will help us to do. Furthermore, Epic doesn't influence the price of medications or the drug benefits, so regulating us like a PBM not only misaligns with our business model and function, but will not bring any greater prescription drug transparency. Thank you very much. Thank you for sponsoring the bill.
Thank you. And now we'll hear from James Doyle.
Jim Doyle on behalf of the Independent Pharmacies of Maryland. We're favorable with amendments. We only have one small issue with the bill. As it stands now, if a PSAO enters into a contract on behalf of an independent pharmacy, it has to provide a copy of that contract to the pharmacy. And I've practiced law for a long time, and that's always been my experience, that if someone signs a contract on your behalf, you get a copy of that contract almost immediately. This bill, in its present form, would change that, and we just have an amendment, and on the other side, the cross-filed bill, Delegate Kelly, who's the sponsor, has agreed to that amendment over there, and we are simply, and I've attached it to the written filing, we're simply asking for the same amendment over here, so that when a contract is entered into by a PSAO on behalf of an independent pharmacy, that the independent pharmacy will get a copy of that contract, whether it's physical or electronic. And that's the extent of the amendment.
Thank you.
Madam Chair, my understanding is the council does have that amendment.
Thank you. All right, finally, we're going to hear Camille Fish and Michael Johansson.
We already spoke favorable on the bill, ma'am.
Oh, we are done. Okay, all right. All right, we're next going to Senator Carozza, Senate Bill 891. And let's see, we have the following persons who can come up to the witness table. Michael Talkington, Deborah Bricado, and Eileen Roberts. If those persons are here, you may come to the witness table. Madam Sponsor, you have the time that you need to lay out the parameters of your bill, and the witnesses will have 2 minutes each.
Thank you, Madam Chair. For the record, Senator Mary Beth Carozza, proud to represent Worcester, Wycomico, and Somerset counties. And I'm here today to present to you the members of the Senate Finance Committee, Senate Bill 891, the Maryland Parental Involvement Enhancement Act. And this bill would require parental notification of non-emergency medical procedures, including abortion, and it would allow physicians to waive the requirement during a medical emergency or if the minor requests a judicial waiver. I consistently have supported policies that increase parental involvement. Many of you will recall the extended debate we had on Senate Bill 41, which lowered the age of consent from 16 to 12 years old for children in need of mental health services. At that time, many parents, medical experts, and health organizations, they opposed lowering the age to 12 and noted that children simply are not able to safely make medical decisions without their parents or guardians. My purpose in introducing Senate Bill 891 is to protect our children and to let parents be parents. Many well-respected medical organizations like the Maryland Psychological Association and the Maryland Board of Nursing, to name a couple, agree that most preteen and teenage children do not have the cognitive capacity to make medical decisions without parental involvement, and it is not developmentally appropriate to expect them to do so. Senate Bill 891 allows parents and guardians to be involved in assessing the risk, benefits, and impact of non-emergency medical procedures performed on their children. One of my witnesses who presented written testimony, she could not join us, is the former Chief Executive Officer of Peninsula Regional Medical Center, now called Tidal Health, Dr. Peg Nalepa. And you'll notice in her testimony, she is not only a former CEO of this medical facility, but she's previously served as a surgical nurse who managed informed consent processes for minors. She's a mother of 2 daughters. She's a nana to 2 granddaughters. And she points out in her testimony that research supports that individuals under a certain age are not sufficiently mature to make clinical decisions. And in her opinion, the reality is the adolescent brain is inconsistent and decisions are often done with little consideration of both short-term and long-term benefits. She also points out that in the proposed bill, physicians may perform the procedure without notice to a parent if, in the judgment of the physician, notice to a parent or guardian may lead to physical and emotional abuse of a minor. This is a very important element and authorizes the physician to apply his or her professional training and judgment. Further, she points out that as a registered nurse with 45 years of experience, she's had numerous occasions personally and has witnessed and has been informed by a minor of a decision that he or she made independently without parental discussion and consent, and the narrative often goes like this: if only I had known, on both the short-term and the long-term unintended consequences. They say that they would have chosen a different outcome. She also points out just being an advocate for parental inclusion and notes, I believe in our parents and their ability to appropriately act as guardians and protectors of their children and the family unit. This proposed legislation honors their fundamental rights and provides exemptions when indicated to protect the minor. You will hear from the witnesses, Michelle Talkington, a mother of 6 children, who will share 2 personal experiences that makes the case for strengthening parental involvement in protecting our children. You also will hear from Deborah Bricado, a registered nurse, who will further explain the importance of this legislation, especially at this time coming out of the COVID-19 pandemic. I encourage you, my friends on the Senate Finance Committee, to work with me on the Maryland Parental Involvement Enhancement Act, and I respectfully ask for a favorable report on Senate Bill 891. And Madam Chair and members, I thank you for your kind attention and consideration.
Thank you. I do have one question. It was interesting to hear you say that you feel that medical practitioners can sometimes, I guess you might consider them very often, make a decision that would be reasonable regarding when there is the right relationship between the child and the parent, and when the parent is going to be, of the pregnant child, is going to be responsible enough and caring enough to help the situation rather than to create more havoc. What makes you so certain? Don't we have a full range of behaviors and of levels of responsibility among all adults as well as among children?
Well, my comments about the physician is we wanted to make sure in the bill that if the physician thought that giving notice to the parent would somehow harm the minor, that the physician could then perform that if they thought there was a risk to the minor. We thought that it was important to have that exemption in the bill.
I just was wondering, though, the physician may never have seen the child before or the parent. Anyway, I just was wondering about that. Okay. Okay, let's go to your Ms. Talkington.
Good afternoon, Madam Chair, Vice Chair, members of the committee. For the record, my name is Michelle Talkington, and I appreciate the opportunity to be here to speak in support of Senate Bill 891. And this bill will ensure the very basic rights of parents and guardians of children. It's my strong desire that you give this a favorable report. As stated, I have 6 children, 3 sons and 3 daughters, and from the moment I delivered each and every one of them, I knew that I was going to raise, care for them, and protect them all the way through adulthood. So at the core of this issue, Senate Bill 891 is the question of whether or not these are my children. At what point is a child an adult capable of making permanent, life-altering medical decisions without notice to their parents? We witnessed SB 41 alter that minimum age, as mentioned earlier, from 16 to 12 for certain cases. Well, I've raised at least 3 of my children past the age of 12, and I can tell you their cognitive abilities are very different. It's frightening for me to consider that this might ever be applied to other non-emergency medical treatments, especially as dangerous or life-altering as an abortion. And to better illustrate my point and the importance of SB 891 as requiring parental notification and stipulations that are provided, I want you to know that I sought treatment for my oldest daughter for a feminine issue. I took her to the doctor and was misdiagnosed 3 times from a very well-respected HMO facility. I had to question that facility and doctor and took her for a second opinion where she was properly diagnosed, and I got the right diagnosis and medication and was told that what she was given actually exacerbated her problem. And that is my concern here. If I wasn't there and that wasn't on my watch, would a child be able to stand up to the authority figure and say, this might not be right, it's not in my best interest? And I've been on the other side of this bill. I was pregnant at the age of 16. And my mother was contacted, and I had someone there to help me decide what was best, someone who knew my experiences. Neither of my parents lived in the state, but they knew they wanted to protect me. And that child I mentioned earlier was that daughter that I delivered at the age of 17. And now 6 children later, I just want support so that we as parents have the ability and opportunity to be responsible, to help our child, because we know best. At the end of the day, parents make the best decisions and know our children. Thank you. I ask for a favorable report.
I would remind you that sometimes the parent is the problem, and there are children who are pregnant because of incest. The people that should have loved them and protected them, in fact, are the problem. And just as you found that one physician was not helpful and you were discerning and you went to another, you might depend on the wrong physician in a given case. You don't know. All right, thank you.
Yes, Madam Chair. Thank you.
All right, let's hear from Deborah Mercado.
Hi, I'm Deborah Mercado. As a nurse, volunteer, and mother to 4 daughters, I support Senate Bill 891, which seeks to restore a certain amount of parental rights. Last year, this legislature passed the Mental Health Access Initiative, which lowered the age of consent from 16 to 12, and that undermines parental rights. While I understand the law sought to address problems, as Madam Chair has addressed, that arise when there is not a healthy relationship in the home, those cases are exceptions. Instead of finding solutions for those minors that may need to distance from their parents, the Mental Health Access Initiative obfuscated the rights of all parents, leaving potentially life-altering decisions in the hands of strangers. This is from the NIH website. It's an article on their website that addresses the adolescent brain. Adolescence is a tumultuous time full of changes and transformations. The adolescent population is highly vulnerable to driving under the influence of alcohol and social maladjustments due to an immature limbic system and prefrontal cortex. Adolescents may become involved with offensive crimes, irresponsible behavior, unprotected sex, juvenile courts, or even prison. And there's much more, and I would hope you would look up the entire article. It's very detailed regarding the development of the brain and the effect that biological chemicals and hormones and external factors have on the development of the adolescent. Parents are the ones who know their children the best, and in most cases will have the best interest of those children in mind. We know that the teenage years are challenging, even in all this in stable homes. The article does a good job of explaining why. We also know too well from the case of the gymnast and Larry Nassar what can happen when trust is misplaced. Parental rights need to be respected, especially in healthcare decisions for minors. If a minor daughter is seeking an abortion, the minor girl has engaged in sexual intercourse. As the article points out, teenagers make impulsive decisions. Parents need to know what's happening in their children's lives to effectively minister to them and provide proper care and counseling. Having sex as a minor is serious, having an abortion is serious, and poses risk of injury and death. A minor does not have the reasoning ability to consider all of the consequences of a permanent action for a temporary condition. A relative stranger cannot accurately assess the needs of this minor girl. Teenagers often exaggerate and say, "My parents will kill me if, ... But this is an exaggeration. Most often, parents are upset when learning of unpleasant information, but they love their children and ultimately want to help them navigate difficult situations. So I urge you to be in favor of this bill. Thank you very much for listening.
Okay, and that mic is movable, if you can move it right over. Okay. And Eileen Roberts.
Thank you, Madam Chair. I appreciate being here today. My name is Eileen Roberts, and I'm the founder and president of an organization, Parents for Life. Parents for Life serves as a collective voice for parents, educates the public, and informs state legislators of the need for public policy that protects minors and the rights of their parents. The Orwellian nightmare began when I wondered why my 14-year-old daughter was severely depressed. Believing her boyfriend had introduced her to drugs, we searched for answers. It wasn't drugs at all. We discovered a questionnaire she hid under her pillow, which she forgot to mail back to the abortion clinic. While in the hospital for follow-up care for depression, it was determined or discovered that her legal abortion was done incomplete, and she had to have follow-up surgery to repair the damage done by the abortionist. But she couldn't have that surgery unless I signed a consent form for the abortion, but yet I didn't even have the right to know that she was in the abortion clinic. To add insult to injury, my husband and I were responsible for the follow-up costs of surgery and care for depression amounting to $27,000. Maryland parents deserve better. This bill does not in any way restrict women from having any medical procedure. Instead, it protects parents from what happened to me from happening to their daughter. common sense legislation. Parents want to know that their teen daughter is having any medical procedure. Our daughters can't get aspirin in schools or have their ears pierced without parental knowledge, and certainly without consent. Parents want to put their arms around their daughters and say, I love you. We can work this through together. I am not naive, knowing that there are many teens from abusive homes. However, what clinics are doing, not only in Maryland, but throughout this country, is giving teens secret abortions and sending them home to the abuser, not reporting abuse against the laws of the country, and our teens need protection from predators. Please pass this bill, which would protect teens, ensure parental rights, the right to know, and also restoring family dignity. Thank you.
Thank you. Senator Reedy?
Just very quickly, if I could ask the sponsor a question, and thank you all for your testimony. I think it's very compelling. Senator Croza, it seems to me we have a little bit of a cognitive dissonance in the General Assembly about kids, their ability to make adult decisions, be held accountable for adult decisions, and parental involvement. It was reference to dealing with mental health counseling and mental health, that legislation from last year. We've also had a lot of things dealing with juveniles who commit crimes, including very serious crimes. We have legislation on the floor of the Senate right now to try to make sure their parents are with them, or at least notified, and an attorney's present when they're being talked to, interrogated by police. We've had legislation in the past couple years that let violent juvenile people who were convicted of very, very heinous, serious crimes as juveniles now get to go. We can have them go free. So, could you talk a little bit about how this bill really comports with the idea that if children's cognitive ability and their brains are not fully developed by the time they're 18, certainly if a 14 or 15-year-old has found themselves in a situation where they're pregnant, that it's really important that unless there's a reason for not telling a parent that this ought to happen. Could you speak to that?
So that's why I wanted to include the testimony from Dr. Peg Nalepa, who specifically talks about the cognitive development with our teens. And I just want to be clear on this bill. It really is to, have the parental involvement in the non-emergency medical procedures, but to have that exemption that the chair and others have referenced, that if at any point that there is this, it's revealed or there's the concern that the abuse might be coming from the parent, that having that doctor being able to waive this. So I want to be very clear on that. This is really focused on more parental involvement, giving the parents, as I like to say, let parents be parents. And so that is really what this is focused on, but we wanted to put the safeguards in. And I think it is significant that other medical organizations, when we were going through the debate a couple years ago, last year on going from 16 to 12, there were several medical organizations that noted the cognitive developmental constraints of it for a teenager. So, but again, I'm trying to be very clear. This is, for non-emergency medical procedures, and we do have the safeguards and the exemptions in place in this legislation.
Thank you. Thank you, Madam Chair.
Okay. Don't see any other questions, so thank you very much. Okay, now let's, let me call up Pam Casemeyer, Robin Elliott, and Lorraine Ruth. You may go in any order. You have 2 minutes each.
Thank you, Chair Kelly. Chair Kelly, members of the committee, good afternoon. My name is Robin Elliott. I'm here today on behalf of both Planned Parenthood of Maryland and the American College of Nurse Midwives of Maryland. We are in opposition to the bill, but I want to start off by saying that we are in agreement with the bill sponsor that most of the time parents should be involved in medical decisions. The current law allows for physicians to provide abortion care with notice to the parents, with several exceptions, including medical emergencies and if there is a risk to the minor because of suspected abuse or any other issues at home. As we read this bill, the physician would be required to notify the parent of an abortion of a minor or the guardian of certain disabled adults before the abortion could be provided. The only exception is a medical emergency. We did not read an exception for suspicion of abuse or problems at home. And the only way then the minor could obtain abortion care is to go through a judicial waiver process. We're very concerned about that part of the bill because we think that if minors decide that an abortion care is the best option for them and a parent or the guardian of a disabled adult disagrees, those individuals will be pressured to carry a pregnancy to term, even if it's against their decision. And with that, we would ask for an unfavorable report.
Okay, thank you. Who'd like to go next?
Hello, Madam Chair, members of the committee, Pam Casemare. I'm here on the behalf of the Maryland chapter of the American Academy of Pediatrics and also the Maryland chapter of the American College of Obstetricians and Gynecologists. And I won't repeat all that Ms. Elliott said. We would agree with things she had said, but I'd raise a few additional issues. There were several comments made from the proponents about consent for, or parental involvement for medical procedures. Aside from the discussion on abortion, no other medical procedures do minors now have consent for. The area in our law that does provide minor consent authority under certain circumstances, substance and alcohol abuse, sexually transmitted diseases, there is the notice requirement for abortions, that's in there, but there aren't other medical, non-emergency medical procedures. They do require parental consent now. So this bill makes that all very confusing. So it isn't the parental involvement, but I think as Ms. Elliott said, our concern is, and this is what we see, and the Academy of Pediatrics was very adamant about this, the adolescent medicine docs particularly, there's sometimes things where they're afraid, well, maybe it was because the pregnancy resulted from a family member, or maybe it's because they're afraid, they don't know what to do, they're confused, and you have granted the providers the authority to make an assessment as to whether they're mature enough to make a decision. Are they at risk? But you also have in the law that they can agree to allow the minor to consent and still talk to the parent, independent from the minor. That's in the current law right now. So the judgment of the clinician is on both sides of that consent.
Okay, thank you. All right, and here finally, Lori Ruth.
Good afternoon, Madam Chair, members of the committee. My name is Lori Ruth. I'm the legal director at the Women's Law Center of Maryland. We advocate for laws that assist women and children and families in the state of Maryland. And we're here to urge an unfavorable report on SB 891. I concur with everything my colleagues, Ms. Elliott and Ms. Casemire, have said, but I just wanted to focus quickly on the judicial waiver portion of the bill. As you can see, if you read the bill, this portion starts on page 4, about halfway down, and it comprises the entire rest of the bill. It's very unwieldy. So imagine a minor who finds herself pregnant, who doesn't want to carry the fetus to term, and who is too scared or too estranged from her parents to go to them, or like the chair mentioned, the pregnancy could be a product even of incest. So they have to embark on this odyssey of judicial waiver. It's complicated and onerous, And asking a person in this position to try to access this process timely and go through this process is extremely unrealistic. We at the Women's Law Center work with many thousands, quite literally, of adult self-represented litigants in the court system who are trying to even get their first foot in the door to figure out how to get there and who to talk to. And it's not that easy for people to do. It's not a process that is easily accessible to the public. And they get very daunted by the judicial system. And in addition, in some communities, there's real distrust of involvement in the judicial system that we have to recognize. This provision is not useful and presents a barrier to these minors getting help. For these reasons and the others mentioned, we urge an unfavorable report on Senate Bill 891. Thank you.
All right, are there any questions? All right, thank you very much. Okay. That ends the testimony on that bill. All right, we're going next to Senator Kagan, Senate Bill 712, Consumer Protection, Scanning or Swiping Identification Cards and Driver's Licenses Prohibitions. And her major witness is Franz Schneiderman. Franz, if you want to come up.
Thank you, Madam Chair, colleagues. This is my last bill hearing. I am seriously going out to celebrate, and you are going out to celebrate because I won't be back again this year. Right? Okay. Let's do the happy dance. For the record, Cheryl Kagan, very proud to be the senator for Gaithersburg and Rockville. Colleagues, this is a bill that you have both killed and passed unanimously. So I am hoping this is the year to pass it unanimously through the Senate, as happened in 2019, and let's get it through the House. It is ever more urgent, and it deals with identity theft. More and more companies are using all of the data and the eagerness to get and sell data that is on our driver's license, and it is unfettered. Maryland does not have any restrictions on the use, on the frequency of the scanning, on the retention of the data, on the selling or giving or using the data. And it's bad enough when we had driver's license and they were taking our name, address, our driver's license number, our photographs, our signatures, our height, our weight, our organ donation status, blah, blah, blah. But now with Real ID driver's license, they get even more stuff from us. And I think we've got to put a stop to that practice, except where it is needed. 12 other states have already enacted these laws, and I want you to hear that these are Republican states, Democratic states, and they date back to 2003. So this has been law in a bunch of states for a long time, and I fear that Maryland is really behind. So to give you an idea, in alphabetical order, California, Florida, Georgia, Hawaii, Nebraska, New Hampshire, New Jersey, Ohio, Oregon, Rhode Island, Texas, and Virginia. Virginia most recently. Identity theft is a huge and growing problem, and hacks are an enormous problem. So Wegmans, and I'm going to use the most ridiculous example, with forgiveness to the lobbyist here who represents Wegmans and does a good job. They wanted an exemption so that people could join their birthday club. And so customers at Wegmans could come in, have their driver's license scanned so they could join the birthday club without a typographical error. And then who knows how securely Wegmans keeps their personal data, whether they sell it, how it's used, and there are horror stories that are around as to how this information is used and misused. 13 million people were hacked in 2019, and we've all seen, whether it's been Facebook or LinkedIn or, all of these big companies, no one is immune. Target, all these folks. So in my testimony on page 2, I did a really succinct where you may scan and where you may not. And we have learned from the 12 other states, and we have taken the best practices, and we have an amendment, and it just trims it down and makes it tight so that what is required by law So if you're going to rent a car, they should be able to scan your driver's license. That makes total sense. If you're going to open a bank account, they should be able to verify that it's you and scan your driver's license or ID card. But if you want to join a birthday club, I think they could probably hand type it, and I think that's okay, and they shouldn't have access. I'm just going to close because I really do want to not take too much of your time. EPIC, which is the Electronic Public Information Center, very widely respected national organization related to electronic use and abuse of our data, said that the best defense against data breaches is not collecting and retaining personal data in the first place. Madam Chair, colleagues, this is the simplest way that we can make sure that we are protecting folks. Where it should be done, where they should be able to have access to the data, let's allow it. But if not, let's put some restrictions so that our Marylanders are protected from identity theft and cyber attacks. Really appreciate your consideration, and I'm hoping for another unanimous report from this committee. Thank you.
Thank you. Are there any questions? Yes, Senator Jennings.
So the example you gave of Wegmans with the birthday cake, isn't it choice, though, for if I'm going to go get a birthday cake for my good friend here to my right, and like, how do you spell his last name? I'm like, it's a chocolate bar, but if you don't understand it, here's a copy of his driver's license. That's my choice to do that, right?
So to be clear, it's not, if I said birthday cake, that was my goof. It's the birthday club, and I guess that, and I probably shouldn't have even said the name of the store. I should have said a grocery store. But if they ask for your driver's license because they raise scare tactics, that the lines would be all the way out the door and around the corner with people waiting while the clerk types in your birth date. I think that's not a valid concern. If the committee chooses, because the legislation is in your possession, if you say that if you want to be in a birthday club at a store or if you want to opt in, then that's your choice. But I think there are too many people who are not so educated, not so informed about the implications. And they say, sure, here's my driver's license, and do with it what you will, because they don't have an idea about identity theft, and they don't know, and they're not going to ask questions about how you're storing my data, and are you going to sell it? What are you going to do about it?
So what is the difference of the data on your driver's license versus Real ID versus the old driver's license?
That is a great question. I have a whole list. I can tell you briefly, Real ID contains even more sensitive information than the regular driver's license, and as everyone knows, by next year, we have to all have Real ID driver's license. It's a federal law, and we're not going to be able to get on a plane or anything without it. But fingerprints, biometric information, facial recognition templates, medical information, court-ordered restrictions, there's a lot of stuff. And again, we have zero knowledge or control over how businesses exploit or use our personal information.
So my driver's license.
Yes.
I don't see that information on there. So
Yeah,
if I hand it to Wegmans that you've called out for the birthday club, like, hey, I want to join your birthday club, here's my birthday, it's legit.
Yep.
How are they getting my fingerprints off of that?
Great question. There's a barcode on the back. And what you're using when you're scanning, and whether you're swiping or scanning, there are more and more devices that allow you to do this. But there's a bunch of hidden information. Now, I don't care if the whole world knows that I'm an organ donor. And I'll tell Wegmans that I'm an organ donor and all that. But my driver's license number, that's confidential. I don't need my home address everywhere, my height, my weight, my photo, my signature, and then some of this biometric information. It's a little scary.
Are you sure, are we guaranteed that those scanners are picking up that data?
So not every scanner will pick up every piece of information, but I can tell you this is a gold mine of data, and there are more sophisticated scanners that are being marketed. My staff just mentioned that if you Google scanning at bars, so more and more bars and restaurants are wanting to scan you, and they say, Senator Jennings, we just want to make sure you're of drinking age. But actually, if they scan you and they keep your information, they're able to do a lot of marketing to you. They're able to, again, retain and sell your information. I don't think that's a slippery slope we want to start going down. And they say they're just checking your age to make sure that you're of drinking age. But the barcode, thank you, the barcode is unencrypted and can be accessed easily. Again, that's a little scary. 12 other states, most recently Virginia. I really hope that Maryland becomes state number 13.
Okay. Seeing no other questions, okay, Franz?
Thank you. Thank you, Senator Kagan, Chair Kelly. My name's Franz Schneiderman. I'm with Consumer Auto. We work for safety, fairness, and transparency for Maryland drivers. But, you know, I'm a consumer advocate, and I'm really interested in this bill as a consumer privacy protection. You know, and we support it because it provides some important additional protections. You know, as Senator Kagan explained, there's a huge amount of information on your driver's license. And that makes it a gold mine for identity thieves. I think it's well known, millions of people suffer from identity theft every year, and it's a real problem for people to sort that out. Now, you know, if you look on the internet, by the way, you can find, you know, all kinds of scanners available, any kind of search for, you know, $100, $150 that are marketed saying that this will enable you to scan and save the information on hundreds of people. Now, they're meant, I think, for restaurant managers who need to scan and save information to check IDs and so forth, but any person could go on the internet for, you know, $50 or $100 and buy these things and use them to capture information on your driver's license. What's important about this bill is that, you know, it defines who can collect that information and who is not allowed to collect or save or store or sell that information. I mean, it might seem obvious that people who don't need to have that information shouldn't be able to do those things, but right now I don't think Maryland law actually prohibits people who don't have a good reason for getting that access from collecting it and storing it. So this bill makes that explicit and makes it a violation of, makes it an unfair and deceptive trade practice, which comes with, you know, fines for businesses and citations and criminal penalties for individuals who do it. And that provides an important additional protection to privacy. So support the bill. Hope you'll give it a positive.
The bill as amended.
As amended.
As amended.
Okay. See no other questions. Thank you very much.
Thank you all.
Okay. We're going next to Senator Lee. Senate Bill 643, Commercial Law, Maryland Personal Information Protection Act revisions. And we'll bring up your witnesses, Hannah Abrams and Bryson Popham.
Thank you, Madam Chair. This is SB 643, is a data breach notification update for Maryland's Personal Information and Protection Act, which we call PIPA. The provisions of this bill aim to improve the security of how information that is sensitive about an individual is stored and how notice is provided to affected consumers, and to meet the threshold security required to be exempt from any of the notification requirements under law. A business merely has to put the personal information behind a firewall or encrypt it. If you use either of those methods to protect your personal information, this law does not really apply to you. However, you fail to protect the data, then it is, and then it's breached. You have to disclose that fact and provide notice to the parties who would be harmed. Under current law, PIPA requires notice as soon as reasonably practical, but not later than 45 days after the business concludes its investigation into the breach. This bill triggers the notification clock to start counting when a business discovers a breach, so that it is not too late and the consumer can take appropriate quick action. Many other states use the same trigger, including but not limited to the state of Colorado, Florida, New Mexico, Ohio, Tennessee, Vermont, Washington, and Wisconsin. This bill also updates the notice timeline when there is an investigation, but there is an amendment that clarifies there would still be underlining threshold of 45 days. Amendments further clarify that the notification requirements for genetic information that is de-identified to satisfy industry implementation concerns, which we have been working with the stakeholders. This is not a rehash of the larger consumer protection issue of control of your data. This bill would not prevent Dr. Evil from using your DNA to make you a mini you, but it would require him to put that data behind a firewall. Other laws may apply to attempted world domination. There is a need to protect how data is used, but this bill is only about how data is stored and the minimum requirement of notice if it has been compromised. The new provision about genetic data is focused on encouraging encrypting it of your genetic information and then letting you know if it's been acquired by someone unlawfully. This is and has been a consensus bill for some time, and we've been literally bending over backwards even more so in this year's version. There are pro-industry group changes like the clarification that you need both the name and personal information to trigger notification requirement that is ambiguous under the current law. The statute merely requires reasonable protection of personal data and notification to the consumers and Consumer Protection Division at the Attorney General's office if there is a data breach. The cross-file bill, HB 962, has already passed the House of Delegates, and the amendment that was attached to further the compromise can be viewed here and will be uploaded for the committee's file. As I said, this was a compromise in 2020 and again last year, but this session we have had the time to get it. We want to get it passed so that at least data is protected by the companies that have control over that data, because it is not controlled by the consumer until we pass more sweeping legislation like my bill, the other bill, the Online Consumer Protection and Child Safety Act. And we hope for these reasons that you will vote favorably on SB 642 with the amendments that we have submitted to the committee. Thank you, Madam Chair.
Thank you.
Mr. Vice Chair.
Comment, interesting bill, looking into it, but as nefarious as Dr. Evil is, I don't know if he would follow this bill and stay within the law, so I just want to say that.
Okay, well, we're going to hear from the law in a minute.
Okay.
So why don't
Go ahead, Hannah.
we hear from Hannah Abrams from the Office of the Attorney General.
Thank you, Madam Chair, committee members. My name is Hannah Abrams. I'm an Assistant Attorney General in the Consumer Protection Division of the AG's office. Thank you for letting me speak today. As Senator Lee explained, this is not a privacy statute that we've been discussing in other cases this session. This is a data security statute. It focuses on amending the Maryland Personal Information Protection Act, which requires businesses that collect consumer data to maintain it securely and to notify consumers if there's a breach. In other words, if you collect it, protect it. SB 643 is the result of extensive negotiations conducted by the sponsors with the various stakeholders. I'd like to commend the sponsors and their staff on their leadership in this area. SB 643 does three things primarily. It adds genetic information to the information that's identified as personal. It makes tweaks to the deadlines for notice, and it streamlines the information that the AG's office collects to make it more efficient when there is a data breach. There's a little, you'll see if you look at the amendment that's been introduced that there's genetic information twice. What that is doing is if it has there's an underlying obligation to protect genetic information with reasonable security. But there was some concern about the focus on de-identified data. And if it's maintained in a de-identified form, then the notice cannot go to consumers. So what the amendment does is it distinguishes between de-identified data and data that's attached to a name. And only in the case where it's attached to a name does a consumer need to be notified. And that's to avoid having to re-identify anything. I'm happy to take any questions, and we urge a favorable report.
Okay, are there any questions? Okay, well, not at this time. Okay, Bryson?
Thank you, Madam Chair. Members of the committee, Bryson Popham on behalf of T. Rowe Price. You have my written testimony along with an amendment, which I am in the uncharacteristic position of asking be withdrawn at this point. I'd like to express my thanks to Senator Lee and her staff, also Ms. Abrams and her colleague, Mr. Sakamoto Wengel, for an extensive discussion of our amendment prior to this hearing today. And we may come back to the committee, and we will not take a great deal of time to do that, with another amendment if appropriate, but we're not prepared to offer it at this point. What we do want to say is that T. Rowe is in a different position, and we want the committee to be aware of that. They are what we would call a service provider. That is not a defined term, but for example, T. Rowe, as a major mutual fund complex, they also provide management services for employers who have, for example, 401k plans, and they are charged with managing them for them. They also manage the 529 plan for the state, as you know. And in that capacity, they are responsible for compliance with certain statutory requirements, including some of the ones under this bill. We had thought that our amendment was clarifying, and I always listen carefully to my colleagues, and have done so with Ms. Abrams and Mr. Sakamoto Wengel, and believe that the amendment, if we offer one, will need some work. So therefore, at our position right now is we are in support of the bill. We are not offering an amendment on the bill. Thank you.
Okay. Are there any questions? All right, thank you very much. Okay. So now he's no longer, let's make this a favor. Okay, and our final bill, oh no, we got two, okay. Senator Reedy, 535. Unborn Child Protection from Dismemberment Abortion Act.
Yes, ma'am, and I think I have one person on my panel, or I don't know if two people's a panel or not, but here we are.
Okay, Deborah Mercado is
Yes,
the
thank you.
one I see that is a favorable. Okay. Okay, you may begin.
Thank you, Madam Chair and members of the Finance Committee. Senator Reedy here for the record to present Senate Bill 535, Unborn Child Protection from Dismemberment Abortion Act. The issue of abortion is obviously a big one that's been discussed this session. There's a lot of legislation on that issue. What this bill does is seeking to end an inhumane and unnecessary manner of performing abortions. Now, I'm pro-life. I have strong views about abortion. I know many of you on this committee don't have that same position, have a different position on the issue of legalization, legality of abortion, and all the things that go along with that, access to. This is not really about whether abortion should be legal or not. That's not really up for debate in this state anyway, despite what you may hear in the media, or with some of the bills that have been introduced. This is about the kind of state we are and what we allow when we allow procedures that strip away the humanity and dignity of a living being. This is about what we're going to allow as we allow abortions. 10 states have passed laws as of 2020, the end of 2020, and it's been introduced in some other states, this legislation. But dismemberment abortions are a disturbing procedure carried out in terminating the life of an unborn child. Dismemberment abortions involve utilizing instruments such as tongs, scissors, and similar tools to extract the fetus from the womb, one piece at a time. It's an incredibly painful process, particularly after 20 weeks for an unborn child. There is no aim at the particular part of the fetus or the body. The abortionist pulls, twists, pries, whatever appendage is easiest to reach. The result is the mutilation of the fetus, the unborn child, during the termination of the pregnancy. And there are many different ways to perform an abortion. This is the most common way to perform an abortion. Why is it the most common way? Is it because it's the healthiest for the mother? No. Is it because it has to be done that way? No. It's because it's the cheapest. It's the least expensive way to perform an abortion. So Senate Bill 535 doesn't attempt to ban abortions. That's not this bill. All it seeks to do is say we should have humane practices when this procedure is performed. It simply prohibits the dismemberment in an abortion. There is an exemption for cases of threat to health of the mother. There's the exemption language that is typical when we do exemptions for abortion policy. I'd ask that you vote in favor of protecting the dignity of human life and support this bill. And I included in your testimony, I'm not going to hold it up or show it, but I included some description, some visual to understand sort of how that process goes about. And so it's in your testimony. But I'd encourage you to look at this bill and look at it separately from the abortion debate about whether abortion should be legal or not, or how much access we have and all that. To me, this is a very simple issue of we want humane practices in our state. So with that, Madam Chair, I ask for your support and the committee's support, and be happy to answer any questions, or we can have the other witness go now.
All right, we'll let the witness go.
Okay, hello again. Senator Reedy accurately described what a dismemberment abortion is, the tearing apart part of that child as it's being killed during this abortion. And according to the Lozier Institute, many studies have shown that the unborn baby feels pain at 12 weeks. This type of abortion is done between 13 and 24 weeks, and as he stated, it is a very common abortion. Our laws need to protect and defend the dignity of the human being, including the unborn child, always, but especially when this child is capable of this type of just heinous pain. We're horrified when we hear of a murder and/or torture where a victim has had their limbs cut from their bodies before or after death. Why is this acceptable for a defenseless baby? It's difficult to think about what this child is enduring. I believe if this procedure were thoroughly explained to women seeking abortion at this point in their pregnancy, they would refuse it. I've worked at a crisis pregnancy center, and I have held and hugged women who were there to support their current pregnancy, but have experienced an abortion prior around this time. And without knowing the type of abortion they received, they regretted the abortion they had, and they were crying about it, that they had killed their baby. I can guarantee that if they knew this is what happened to their baby, they would never have gone through with that abortion. They only did it because they felt no one would support them in this unexpected pregnancy. So in addition to what's happening to the baby, though, we must consider the health and well-being of the mother. The mother is at risk of complications due to the sharp instruments used during this abortion and the sharp edges of the baby's bone fragments caused by the dismemberment. She's at high risk for damage or perforation of her uterus, cervix, and other organs nearby. She's at risk of hemorrhage, infection, failure to carry a future pregnancy to term, and even maternal death. All of this can be found in medical articles and journals. In Maryland, we know about these complications at the hands of Leroy Carhart. I urge you to protect and defend the humanity of the baby. I would not make exceptions for rape and incest because the baby should not pay the price of what the perpetrator has done to the woman. And an abortion ban outright would be appropriate since, as Senator Reedy described, how heinous this procedure is. It's barbaric, and the Supreme Court has said that it is constitutional to ban barbaric procedures like this. So thank you for listening, and I hope you will vote in favor of this bill.
It does seem like a very invasive bill. I mean, you're talking about some hypothetical situations. You haven't been, and I haven't been in an operating room where somebody else was getting an abortion. And we don't really know what goes on, and if so, why? I'm sure there are medical procedures that have been thought out, and there are some parameters beyond which a doctor can't go at certain points in the development. Let me just say this. About 55 years ago, when I was a graduate student at Purdue University, one of my fellow classmates, a married woman who had a cute little boy, went several times to the health center because she was having problems and they couldn't figure out what they were. And they did several x-rays on her. And finally, what they found out is that she was pregnant, but the fetus was not in her uterus. It was in the fallopian tube. So it was going to die. There was no, and had it stayed there long enough, she would have died of the bursting of the fallopian tube with the fetus in it. We don't know what's happening with people. We aren't reading their private medical records. I took care of a little boy while because in Indiana, they didn't have any abortions and they were legal. And he had to take her all the way, her husband, to New York State was the only thing coming up close by in terms of time. So to save her life, because the fetus would surely die if she died, and that's exactly what was about to happen. So I just think if we don't have a medical degree and we aren't taking care of patients, we shouldn't tell them under what circumstances to do what, because we don't know the particulars in any given situation.
Could I
just thought
address?
I would share that with you.
I'd like to address that. What you were talking about is an ectopic pregnancy, so you're right, when the baby is in the fallopian tube, the baby will not survive. And so that's a different
Well, no, it's really
case.
a subset of what you're talking about. You don't know what else.
Well,
or
but I
things that
will also tell you this, that the girls that I knew from working at the pregnancy center, when they go into the abortion center, they're getting a same-day abortion, so there's not all this, pre-op blood work or studies to determine what's going on with them. It's like they get in there, and they don't want them to leave without that
we
abortion.
don't
This is
know.
what they told, this is from
Madam-
their personal experiences. And I will say that I'm an adopted person, so my mother chose life for me, and I'm very grateful for that. I'm grateful she was able to find the support. So that is what needs to be addressed, is find the support for these women to really give them informed consent and understand. I don't believe that most women understand what this procedure entails, and they're not receiving the full picture.
Well, Madam Chair, the things you've raised are also why there is an exception in the bill, and then why we would have, there's a life of the mother exception. And I'll also say this, you say about, we don't know what goes on. I mean, and whether we're health providers, we really can't regulate. Well, that would eliminate a lot of bills in our committee if we, in the other committee that deals with health occupations. I would just say that this is actually a pretty unregulated industry. There's a lot of things that are not regulated in the abortion industry. This bill is not an attempt to outlaw abortion. It's an attempt to say you can't do dismemberment abortion where you're picking pieces of the baby apart and also not providing any anesthetic. In many cases for the pain. So anyway, I mean, you and I may not agree on this, but that's where we are.
I would like to say another story. I worked at Sinai Hospital, and this was some decades ago.
You know what, we have another, we really can't. We have another sponsor waiting for a bill. We gave everybody, all of the
Okay.
witnesses.
It was just
But if you
an
wanna
amazing
send us
case.
something back,
so-
we would be happy to read it,
Okay, well, thank you, Madam Chair. I appreciate you all listening to me today, and may you all have a good day.
Thank
And
you
happy
for-
St. Patrick's Day
Thank you
tomorrow.
for testifying. All right, now we've got two unfavorables, Robin Elliott and Laurie Rue. Or you have 2 minutes each.
Thank you, Madam Chair. Members of the committee, my name is Robin Elliott, here on behalf of Planned Parenthood of Maryland and the American College of Nurse Midwives, the Maryland chapter. In opposition for the bill, we thank Senator Reedy for always for the discussion, and we know that everyone is coming from a personal place on this issue. The reason that we are opposed is because this is the most, and what it's called is dilation and evacuation procedure. And just wanted to make sure that we had the clinical name to you. That is the safest type of procedure for second trimester care. So by banning this procedure, it would force physicians to use less safe procedures in delivering abortion care. There is an exception for a medical emergency. There are also very heavy penalties. So as we understand from both within our organization as well as colleagues here in Maryland and across the country, that those types of penalties make practitioners hesitant to use this type of procedure if it's banned. And so for those reasons, we would ask for an unfavorable report.
All right, and now Laurie Ruth.
Good afternoon, Madam Chair, members of the committee. My name is Laurie Ruth. I'm the legal director at the Women's Law Center of Maryland. We advocate for rules that support women, children, and families. We are here in opposition to Senate Bill 535 and urge an unfavorable report. This bill is unconstitutional and imposes an undue burden on women seeking to obtain abortion care. Courts in other states have struck this model right to life legislation down. It is my understanding that this is model right to life legislation, which indicates it is actually anti-abortion legislation, despite what Senator Reedy respectfully says. Seeking to prohibit the safest method of abortion in the second trimester is just a further attempt to restrict all abortion, and it's based not on medical or scientific basis. For those reasons, we urge an unfavorable report on Senate Bill 535.
Okay, are there any questions? All right, thank you for your testimony.
Thank you.
And we're going finally to Senator Patterson, Labor and Employment Apprenticeship and Training Council representation. And you have a witness, William Taylor, who may come to the table. You have the time you need to lay out the parameters of your bill, and Mr. Taylor, the witnesses get 2 minutes each.
All right, thank you very much. Thank you, Madam Chair, Mr. Vice Chair, members of Finance Committee. I do appreciate the opportunity to come back before you again and introduce this very same bill second time around. We do thank you for your passage of this bill last year, but for whatever reason, we were unable to get it out of the House, so we're back before you. Mr. Taylor is my only expert witness for the afternoon. We had one or two others, but some things happened and they couldn't make it. But this bill is a very simple, straightforward bill. It talks about the omission. We talk about up here a lot inclusion, and I think that's where we are right now in the midst of trying to do whatever we can to ensure that we get inclusion in all aspects of state government, and so will this bill. The language in the bill from last year in present law basically said wherever practical efforts will be made to ensure that inclusion would be provided in law. This bill makes it clear that we would like for those who have the responsibility to implement the law to not just talk about what's practical, but what will happen. And therefore, this bill is before you this afternoon. And specifically, when we talk about inclusion, we're talking about Black and Latino members in the universe. So I present this bill to you, and I thank you again for your support of this bill last year. And we hope that you will, again, give it a favorable consideration. Thank you.
Okay, thank you. Are there any questions of the sponsor? Okay, then we'll go to Mr. Taylor.
Hey, Madam Chair, I hate to ask, but I got 15 bills we voted on my committee.
Okay, we
If I could
understand.
kindly be excused, I would gladly
If
appreciate
you're
it.
voting, go vote.
We are voting. Thank you.
All right, Mr. Taylor.
Senator Kelly, Vice Chair, and the committee, thank you for having me to come back a second year. Let me get on with my testimony. For the record, my name is William Taylor. Good afternoon, ladies and members of the Finance Committee. My name is William Taylor, Fort Washington, Maryland. I'm the past chair of the Maryland State Apprenticeship Council, where I served for 14 years. I served under 3 governors. My purpose here today is to support Bill 926 that will include representatives by Black, Latinos, females, individuals with disabilities. In addition, consultants to the council shall include Black, Latinos, females, and individuals with disability. This will help ensure the Maryland Apprenticeship Council has diversity in gender and race in the sponsored program. We have developed a deep, abiding commitment to ensure that a balanced representation in employment opportunities. I'm an advocate for opportunities that will support diversity in the workplace and allow all individuals to become productive and contributing members to our community. I applaud the enhanced focus on Senate Bill 926 to include diversity on the Maryland State Apprenticeship Council. The council should look like the people it serves and need representation from all eligible workers. A more diverse council will help with recruiting and increasing the diversity of apprentices. I understand there's a shortage of skilled workers in a number of the trade professions. A number of our communities have untrained workers that could fill these vacancies with the help of an apprenticeship. A more diverse apprentice council will help fill the needs of employers and unemployed workforce. The addition of females and other minorities on the council will only improve workforce development and working conditions within the state. I respectfully ask that we take the necessary action to ensure that this bill pass. We cannot afford to lose sight of diversity at this critical junction. I ask you to take the necessary actions to ensure that the Maryland Apprenticeship and Training Council include representatives of Blacks, Latinos, females, and persons with disabilities. Also, consultants to the council shall include Blacks, Latinos, females, and individuals. Thank you for the opportunity to address this committee, and I hope that we get a favorable decision on the bill.
Okay, thank you. Are there any questions? All right, well, thank you very much for your testimony, and that concludes the testimony on this bill. What'd you say?
That concludes our bill.
Yeah, and this concludes our